Okay, this is chapter 33 when we're looking at orthopedic injuries. That is your national AEMT education. And we'll be looking at recognition of open, closed fractures, dislocations, amputation. Also looking at the physiology of upper and lower extremity trauma, open fractures, and closed fractures and dislocations, some patho stuff. Patho sprain and strains, pelvic fractures, amputations, replantation, also compartment syndrome. So in medicine, some competencies, basically doing a standardized advanced emergency care and transportation based on the findings of the acutely ill patient. And some non-traumatic musculoskeletal disorders, some AEMT patho non-traumatic fractures. So musculoskeletal injuries are one of the most common reasons why patients seeking medical attention. It's easily identified because of its associated pain, swelling, and deformity. However, it is rarely fatal, but often results in a disability. So do not focus solely on the injury without determining that non-life-threatening injuries exist also. So never forget about your ABCDEs. A lot of times when people have fractures, we forget to take care of other things first because of the fracture is so traumatic at times in the way it looks. But first you should be taking care of your ABCs, D, and E's also. The musculoskeletal system does give the body shape and allows it to move. When a muscle contracts, the force generated by the muscle is transferred to a bone on the opposite side of the joint from the muscle. So muscles are composed of specialized cells that contract when stimulated to exert a force on a part of the body. There are three types of muscles: cardiac, skeletal, and smooth. Remember that cardiac moves on its own. Skeletal has to be told, and smooth muscle does contract mostly on its own, but sometimes it has to be told also. So muscle contraction requires energy, which is derived from the metabolism of glucose and results in the production of lactic acid. Muscle innervation. If skeletal muscle is innervated by somatic motor neurons, the combination of the muscle and the neuron, the innervates, it constitutes a motor unit. So recruitment is to generate a more forceful contraction. So more neurons need to signal more muscle cells to contract. The musculoskeletal blood supply is the skeletal muscle is supplied with arteries, veins, and nerves. The blood supply in each upper extremity originates from the subclavian artery. The skeleton is approximately 206 bones. It's divided into the axial skeletal and the appendicular skeletal. The axial skeletal is comprised of the bones of the central part or axis of a body. The appendicular skeletal is divided into the pectoral girdle, the pelvic girdle, and the bones of the upper and lower extremities. Upper extremity is composed of the upper arm, elbow, and forearm. The radius and the ulna make up the forearm. The hand contains three sets of bones. It contains the carpals, the metacarpals, and the phalanges. The pelvis supports the body weight and protects the structure within the pelvis. The two iliac bones are joined posteriorly by ligaments to the sacrum and to the sacroiliac joint. The lower extremity consists of the bone of the thigh, leg, and the foot. The lower leg consists of the two bones, the tibia and the fib. The fibula is attached to the point of the lateral ligaments of the knee joint. So it serves as the lateral stabilizer of the ankle joint at its distal articulation. The foot consists of three classes of bones: the tarsals, the metatarsals, and the phalanges also. A joint is formed whenever two bones come into contact with each other. You can see several joints here. The sutures up there in the cranium, the shoulder joint, um, the hip joint, also your knees and elbows. So motions that may allow a joint to move in different types of ways, and it's listed here. And all those are classified in the particular way in which it moves. Bones are classified based on their shapes. The long bones are longer than they are wide. Short bones are nearly as wide as they are long. The flat bones are thin, broad bones. Irregular bones have complex shapes. The sesamoid bones or round bones are generally found in the tendons. Long bones are long bone architecture is divided into the diaphysis, emphasis, and the metaphysis. Um, the area between the two bones coming into contact to form a joint is covered by a thin layer of articular cartilage. Portion of the bone that is not covered by the articular cartilage is covered by the periosteum. The inner portion of the long bone, the blood comes from the nutrient artery of the bone. Tendons, ligaments, and cartilage. Tendons connect skeletal muscle to bone. Tendon crosses the joint to create a pulling force between two bones when the muscle contracts. The ligaments connect bone to bone to help maintain the stability of the joint and to determine the degree of the joint motion. Cartilage consists of fibers of collagen embedded in a gelatinous substance. Age-associated changes with bone density decreases after the age of 35. This leads to a loss in height and produces a change in facial structure. In women, the decrease in bone density accelerates once menopause is reached. A significant decrease in bone density, osteoporosis, is associated with a higher risk of fracture. The aging of muscle, cartilage, and other connective tissues may lead to degradation of joints and disc herniation. So some pathophysiology injuries that may injuries may result from both blunt and penetrating trauma. Sports injuries account for a significant number of musculoskeletal injuries among children. Intentional trauma or abuse is a common cause of fractures and musculoskeletal injuries. Pathologic fractures occurs when a medical condition causes the bone to become very abnormally weak, such as osteoporosis. For mechanisms of injuries, a significant force is required to cause fractures and dislocations. So you may have things like a direct blow, indirect blow, twisting forces, and high energy injuries. A direct blow fractures to the joint at the a direct blow fractures to the bone at the point of impact. A high velocity injury typically shatters bones and causes extensive soft tissue damage. An impalement injury, similar to that, is seen in a low velocity penetrating injury. So you need to stabilize the object to protect the soft tissues from further injury. So basically you're doing that, you're stabilizing that object so that it doesn't move around while you're transporting the patient. An indirect injury often occurs when force is applied to one region but causes an injury in another region. Forces may be transmitted along the entire length of a bone or through several bones in series. To identify the point of contact and mechanism of injury, to decrease the chances of overlooking any associated injuries. Twisting forces are common causes of musculoskeletal injuries. Some injuries are commonly encountered together because of what the causative forces are transmitted. Fractures occur when the magnitude of the force applied to a bone overcomes the strength of the bone. So some types of fractures are open or closed. An open fracture is sometimes called a compound fracture, A bone in the overlying skin allows the fracture to be exposed to the outside environment. In a closed fracture, the skin over the fracture site remains intact. Angulation is a bone is misaligned as a result of the injury and that an angle has formed between the fracture fragments. A non-displaced fracture is a simple crack in the bone. In a displaced fracture, the two bone ends at the fracture are separated in at least one plane. Terms to describe types of fractures: transverse is A, oblique is B, spiral is C, commuted is D, grain stick is E, and then you got your pathological and epithelial fractures. Signs and symptoms of deformities. Of course, is the deformity itself, like you see here in the lower picture. Obvious misalignment there. That's a closed fracture. Shortening, also, possibly a hip involved. Swelling, like you see in picture A. Bruising, tenderness, pain, guarding. Crepitus, that's a grating sensation of the broken bone ends. And false motion occurs at the point of the limb where there is no joint. Lock joint is difficult and painful to move. In an open fracture, exposed bone ends may be visible. And that's what you see here at the ankle, and that's possibly the tibia or fibula being exposed there. Dislocations, bone is totally displaced from the joint. Occurs when a body part moves beyond its normal range of motion, may spontaneously undergo reduction before beginning an assessment. So partial dislocation of a joint is known as a subluxation. Some signs and symptoms are marked deformity and swelling. Pain, tenderness, virtually complete loss of the normal joint motion, numbness or impaired circulation to the limb or the digits. So consider an urgent injury because of the potential cause of neurovascular compromise distal to the site of the injury. Always assess the patient's neurovascular status distal to the site of dislocation. Sprains, ligaments are stretched or torn, usually result from the sudden movement of a joint beyond its normal range. Some signs and symptoms are point tenderness, swelling, and ecchymosis. Pain causes instability, and it rarely involves deformity. In strains is injury to a muscle or a tendon that results from a violent muscle contraction or excessive stretching. Only minor swelling may be noted at the site of the injury. Achilles tendon rupture. This usually occurs in athletes older than 30 years involved in a start and stop point. Most immediate indications are pain from the heel to the calf and a sudden inability to perform plantar flexion of the foot. Acute management includes rice and pain control. Long-term treatment may involve splitting and surgery. Amputations is separation of a limb or other body part from the remainder of the body. Hemorrhage can be severe and life-threatening. So, if you do have an amputation, you need to take care of that hemorrhage. Don't forget our hemorrhage control protocol. If it is a major hemorrhage, you can go ahead and put a tourniquet on those injuries also. So, with your patient assessment, attempts to split and stabilize the patient's conditions are very important. So do not become distracted by visually impressive injuries. Okay, if you got amputation, don't become distracted because of it. If you got an open fracture, don't forget about your ABCDEs. Take care of those first. The injury has already occurred. Yes, we need to take care of it quickly. However, being taking care of your ABCDEs is takes more prominence over the injury itself. So carefully assess the mechanism of the injury, maintain a high index of suspicion for associated injuries. So identify the injuries, prevent further harm or damage to the injured structure and surrounding tissue. Support the injured area, administer pain medication if necessary. Patients may be classified based on the presence and absence of associated injuries. So life or limb-threatening injury, condition, life-threatening injuries, and only simple musculoskeletal injuries, life or limb-threatening musculoskeletal trauma, no other life-threatening injuries, so or an isolated non-life-threatening or non-limb-threatening injuries. All right, so if you have a life-threatening injury, take care of that. Okay, then we'll take care of your musculoskeletal stuff next. If it's an isolated injury and there's no life-threatening injuries, yes, you can go ahead and take care of that isolated musculoskeletal injury first. Always remember your golden hour, but it's also very important for preserving limbs too. Any suspected open fracture or vascular injury is considered a medical emergency also. So medical will take care of that, and then the trauma team, the orthopedic team will come in and take care of the bones and ligaments fractures. Identify critical injuries by using the musculoskeletal injury grading system. Same size up, of course, always the same. But also be alert for both your primary and secondary injuries. Primary survey, focus on your patient's mental status, age, ABCDEs, and priority. Consider the history taken in secondary assessment in case of non-threatening life conditions. Identify the injuries and prevent further damage. And then evaluate the patient's level of consciousness and orientation. Check for responsiveness using AFP, O2. If it was significant trauma and multiple systems are affected, don't waste time on the same. Okay, 10-minute rule on these patients. One thing you should be doing is getting them stabilized and possibly C-spined on your stretcher, and then you should be rolling off the scene with these patients. Spinal injury suspected, take appropriate precautions, and address the extenuating hemorrhage first, and then address airway and breathing concerns. Assess circulation, treat for shock, and maintain the body temperature. So, all right, your history taking sample. Identifying and putting existing musculoskeletal disorder, PQRST, and the patient may be experiencing acute pain or musculoskeletal injury. With splitting, different things like that, musculoskeletal injuries, a lot of times if you can give pain medication before you actually splint and start manipulating that musculoskeletal injury, it does help. So I know there's not a lot of pain medications at the advanced EMT level right now, so but however, establishing that IV access, getting everything else done, if you do have a medic en route, in a short period of time they can be there. Do not waste time on the scene for this. It does help to go ahead and give that pain medicine before those limbs are actually splinted. Your secondary assessment risks for severe injuries and occur when two or more bones have been broken. So in your physical exam, start with full body scan, identify hidden or potential life-threatening injuries. When examining a stable patient with an isolated injury, obtain a baseline set of vitals, note your DCAT BTLS, and do the 6 P's of musculoskeletal assessment: pain, paralysis, paresthesia, pulselessness, pallor, and pressure. Evaluate circulation, motor function, and abnormal sensation. Consider distracting injuries, assess the entire zone of the injury, and always evaluate the joint above and below the injury. So please make sure, prior and post splitting, that you do evaluate pulses and all these different things. And you need to note both of those prior and post splitting too. Expect for all these in your secondary assessment, it may be getting better, it may be getting worse. So, but you need to note those things. Palpation, palpate any tenderness, palpation of the pelvis, um, palpate maybe a significant sign of underlying musculoskeletal injuries. Palpate above and below the injury site, identify regions of point tenderness, and reassess tender areas. Palpation of the pelvis, apply pelvic pressure over the pelvic, apply pressure over the pubic symphysis to evaluate for tenderness and crevices. Press the iliac wings toward midline and then posteriorly. Do not repeatedly examine pelvis if instability is found. Neurovascular status, assess every 5 to 10 minutes. Always recheck before and after splitting. Failure to restore circulation can lead to death of the limb. To assess neurovascular status, look at skill jewel 33 or more. And always check your vital signs. In your reassessment, repeat the primary assessment. This should be performed every 5 minutes for unstable and every 15 minutes for a stable patient. Most of your stable patients are going to be those isolated, non-threatening, life-threatening injuries patients. All the other patients are going to be probably unstable, and you're going to need to check those every 5 minutes. Recheck your interventions. If you need to increase or decrease some stuff, maybe you start that patient out on non breathing, and SpO2 looks good, and everything's kind of stabilized. You can back those patients down. Make sure you secure them along back boards to stabilize the tight spine, pelvis, and extremities. If the patient has no life-threatening injuries, take extra time at the scene to stabilize obvious injuries and perform a more thorough evaluation. Okay? Then report any problems with ABCs, after fractions, and compromised circulation before or after splitting. You need to report this stuff. We can't control everything. We can't do the proper interventions out in the field. So, you may have a pulse that has decreased because of movement going down the road, but it's just stuff you need to document. Give complete descriptions of injuries in your documentation. Assess and document the presence or absence of circulation, motor function, and sensation distal to the injury before moving an extremity. Always document the findings of neurovascular exam when they are normal. When abnormal is identified, document the specific deficit. All right, first step in the primary survey is stabilize the patient's ABCs. So do that full body scan. Take PSI, be alert for internal bleeding, especially in the abdomen and pelvic areas. Don't forget that those areas can have a large amount of blood, especially in the pelvis, can hold a large amount of volume deficient due to musculoskeletal injuries. Fractures may lead to significant blood loss from damaged blood vessels within the bone. Implement interventions such as direct pressure, splitting, and administer intravenous fluids to prevent the development of hypotension in an unstable condition. Keep the fluid volume, vital size, and mental status normal, and administer fluids at a 20 ml per kg increments to maintain blood pressure and perfusion. Cold and heat packs. Cold packs are useful for treating patients during 48 hours following the injury because it can help keep the swelling down. So it constricts the blood vessels in the region, and it decreases the release of inflammatory mediators. Heat therapy should be avoided in the initial 48 to 72 hours and following an injury. So it may increase pain and swelling during this period because heat opens up the vessels itself. Splitting, unless the patient's life is in immediate danger, and split on fractures, dislocations, and sprains before moving the patient. When those splitting materials are available, the patient's arm can be bound to the chest wall, and the injury leg can be bound to the uninjured leg. So there are 3 major types of splints: traction, rigid, and formable. They do not move the patient before splitting an extremity unless there is immediate hazard to the patient or yourself. For fractures, the splint should be mobilized the bone ends and the 2 adjacent bones. For dislocations, the splint must extend along the entire length of the bone above and the entire length of the bone below the dislocated joint. Pad all rigid splints, mainly support the injured site, with hands placed above and below the injury. The long fracture is severely angulated and no pulse is present in the extremity. Gently apply longitudinal traction. So, when in doubt, splint, apply your cold packs and evaluate the splint limb to minimize swelling. Avoid covering the fingers and toes with the splint. And if the patient reports severe pain or is resistant to movement, discontinue applying traction. Splint the joint or bone in the position of deformity. So do not attempt to straighten fractures involving joints without first obtaining medical direction. Alright, some hazards associated with improper application of splint. Compression of the nerves, tissues, and blood vessels. Delay in transport of the patient with a life-threatening injury. Reduction of distal circulation. Aggravation of the injury. Injury to the tissue, nerves, blood cells, correction, blood vessels, or muscles due to excessive movement of the bone or joint. Traction splints are the most effective way to realign a fracture of the shaft of a long bone. Prevent the broken bone ends from overriding due to unopposed muscle contraction. Reduce blood loss. Excessive traction can be harmful, and do not attempt to reduce the fracture or force all the bone fragments back into alignment. The goals of an inline traction are to stabilize the fracture fragments to prevent excessive movement. Align the limb sufficiently to allow it to be placed in a splint. Avoid potential neurovascular compromise, so use the least amount of force necessary and use primarily to stabilize isolated fractures of the mid-shaft fragment. Okay, so pulling traction on a femur is pretty much the only time you'll pull traction and hold it. And this is to align the bone so that you can place the hair traction in on that femur fracture. Alright, traction splints are pretty much used to stabilize an isolated mid-shaft fracture. And it's got to be an isolated mid-shaft fracture. It cannot be a lower fracture to the tear fib. You can't use a traction splint on that because you're going to be pulling traction on the tear fib and not the femur itself. Alright, do not use traction splints for injuries close to or involving the knee, pelvis, partial amputations or avulsions with bone separation, lower leg, foot, or ankle fracture. Try to assess your pelvis. Sometimes it's going to be hard to figure out which one is injured. It may be a pelvis and a high femur together. You see a lot of people they will splint both. The pelvis may not be unstable. However, they do have pain upon tenderness, so we may put a traction splint on the femur on that side also with a pelvis fracture. So you're going to use your hair traction splint or your sagittal traction splint to help reduce the pain and align that bone a little bit. The hair traction splint and both are mainly used to or both used to reduce pain. That's its main goal. Rigid splints are made from a foreign material and applied to the sides, front, or the back of the injured extremity. You must apply this. You must splint the limb in the position of the deformity when the deformity is severe, resistance, or extreme pain is encountered. When applying gentle traction to the fracture or a shaft of a long bone, apply a padded board splints to each side of the limb and secure with a soft roll of bandages. Most dislocations should be splinted. Pneumatic splints are useful when stabilizing fractures involving the lower leg or the forearm. They're not effective for angulated fractures or for fractures that involve air splints or that involve a joint. Air splints are most commonly used. They come in a variety of shapes and sizes. Always inflate after applying it. Help control bleeding and reduce the swelling. And should not be used in an open fracture in which any sharp bones are exposed. All open wounds should be covered with a dressing before applying the splint, and overinflation can occur when applied in a cold area and the patient is subsequently moved to a warmer area. So carefully monitor the splint and let air out if the splint becomes overinflated. Pneumatic shark garments or anti-shark garments are not used as much. The big problem with these was you inflated them, you put them on, they help, you got to the hospital, and they have to actually cut them off. And then they were just cumbersome a lot of times. So they are contraindicated for treatment of shock. Do not use in the following conditions: pregnancy, pulmonary edema, acute heart failure, penetrating chest injuries, growing injuries, and major head injuries. Inflate all compartments using a device to stabilize the possible framework, pelvic fracture. So never remove it in the field, and report the patient's blood pressure, the time you applied it, and the result. Form of splints include vacuum splint, pill splint, structured aluminum malleable splint, the same splint, splint swath, and pellet binders. A vacuum splint can be easily shaped to fit around the deformed limb. Pelvic binders provide support temporarily, should be light, made of soft material, and easily applied by one person. Buddy splint is used to splint injuries that involve the fingers and or the toe. Tape injured digit to an uninjured one. Alright, transportation. A patient with a porcelain limb must be given a high priority. If treatment is in an hour or more away, a patient with a porcelain limb should be transported by helicopter or immediate ground transportation. If circulation in the distal limb is impaired, consult with medical direction. Musculoskeletal injuries can lead to numerous complications, often related to the strength of the force that caused the injury location, and overall health of the patient. So prevent infection following open fracture by brushing away any debris on the skin surrounding the open fracture before applying the splint. You may also want to rinse it with a sterile water or saline. Long-term disability is one of the most devastating consequences, and administer analgesics if transport, if available. Peripheral nerve or vascular injuries, when blood vessels are damaged following a musculoskeletal injury, devascularization can occur. Displaced fracture fragments may lacerate or impair the nerves. Neurovascular injury is likely to occur following a joint dislocation, and it is important to assess and reassess pulses, control bleeding, and maintain adequate intravascular volume. Compartment syndrome is one of the most devastating consequences of a musculoskeletal injury. The longer it persists, the greater the chance for the tissue necrosis. External and internal factors can lead to the development of compartment syndrome. So open fractures have a higher risk of compartment syndrome because they are typically associated with a higher energy injuries. It usually develops within the first 6 to 12 hours and is characterized by severe pain localized to the involvement compartment. Skin pallor may be apparent, as well as paresthesia. A late sign is the absence of distal pulses in the affected extremity. If the patient has a fracture below the elbow or the knee, ask about the following: extreme pain, decreased pain sensation, pain on stretching of affected muscles, and decreased strength. Management should include evaluating the extremity, elevating the extremity to the heart level, placing ice packs over the extremity, opening or loosening constrictive clothing and splint material. Administer O2 crystalline solution as needed. Administer nitrous oxide for pain management as allowed by your local protocol, and frequently assess neurovascular status. Crush syndrome occurs following the extrication of a release of entrapped limb. Rhamnomyolysis is tissue necrosis leads to release of harmful products. After a muscle is compressed for 4 to 6 hours, the muscle cells begin to die and release their contents into the localized facial vasculature. Treatment should always be performed in the upward direction. So set your ABC, administer supplemental O2, IV boluses, and do not apply a compressive device. Thromboembolic disease includes DVTs and pulmonary embolism, a significant cause of death. Usually when they circulate, they do cause the patient to go to cardiac arrest of unknown origin sometimes. This is something you have to keep in mind, especially when these patients come home after a severe injury and they don't keep themselves moving. So, signs and symptoms include disproportionate swelling of an extremity. So you may have an extreme swelling in one extremity, not in the other one. Discomfort in an extremity that worsens with the use, warmth and arrhythmia of the extremity. So when a DVT dislodges it causes a pulmonary embolism. Signs and symptoms of a PE, some onset of dyspnea, pleuritic chest pain, tachycardia, right side heart failure, shock, and cardiac arrest. Patients with a long bone or pelvic fracture are at high risk for developing fat embolism syndrome. Treatment for fat embolism syndrome in the field is maintaining the airway, O2, intravascular volume, and rapid transport. Pathophysiology is clavicle, certain to specific injuries. Clavicle and scapula is one of the most commonly fractured bones. Fractures of the clavicle occur more often in children when they fall on an outstretched hand. It can occur with crushing injuries to the chest. And a patient will report pain in the shoulder, and we usually hold the arm across the front of his or her body. Young children will also report pain through the arm and are unwilling to use any part of the injured limb. Swelling and point tenderness occur over the clavicle, and because the clavicle is self-contained, the skin will artificially tense over the fracture fragment, so it may lead to neurovascular compromise. Fractures of the scapula or shoulder blade occur much less frequently because the bone is well protected by many large muscles. Result of violent direct trauma to the back directly over the scapula may also injure the thoracic cage, lungs, and heart. Carefully assess the patient for signs of pneumothorax, hemothorax, and rib fracture. Abrasions, contusions, and significant swelling may occur, and the patient will often limit use of the joint between the lateral aspect of the clavicle and the acromion process of the scapula is called the AC joint. It's frequently separated during football or hockey when a player falls and lands on the point of the shoulder, driving the scapula away from the outer end of the clavicle. Dislocation is often called an AC separation. Distal end of the clavicle will usually stick out, and the patient will report pain and point tenderness of the AC. Fractures of the clavicle and scapula and the AC separation can be fatally splintered with sling and swab. Dislocation of the shoulder, the glenohumeral flexion. The glenohumeral joint is where the head of the humerus meets the glenoid fossa of the scapula. Most commonly dislocated large joint in the body, the humeral head is most commonly dislocated anteriorly. It is extremely painful. The patient will guard the shoulder and try to protect. The shoulder joint will usually be locked, and the shoulder will appear squared off or flattened. The humeral head will protrude anterior underneath the pectoralis major on the anterior chest wall. Some patients may report numbness in the hand because of the compromise of the nerves and circulation. Stabilizing the anterior shoulder dislocation will produce pain. Splint the joint in the position most comfortable. If necessary, place a pillow, rolled blanket, or rolled towels between the arm and the chest to fill the space. And apply sling to the forearm and wrist to support weight of the arm. Dislocation of shoulder disrupts the supporting ligaments of the anterior aspect of the shoulder. Dislocation recurs because these ligaments often fail to heal properly. Some patients can reduce their own dislocated shoulder. I call that the Rocky movement. A shoulder dislocates posterior instead of anterior about once in every 20 cases. The arm will be locked in adductive position, and so it cannot be rotated. And reducing this often requires medical direction. Fractures of the humerus may occur proximally in the mid-shaft or distally at the elbow. Proximal humeral fractures from falls are common among older adults. Mid-shaft fractures occur more often in younger patients, usually a result of a violent injury. Radial nerve may be injured by the force itself or becoming trapped within the fracture site. The classic sign is a wrist drop. The fracture is angulated. Longitudinal traction may be applied to correct the deformity. Once the extremity is in the desired position, apply a rigid splint that extends to the axilla to the elbow. Compartment syndrome can develop in the forearm in children with these fractures. Elbow injuries. Fractures and dislocations often occur around the elbow, and different types of injuries are difficult to distinguish without radiogram. They all produce similar limb deformities and require some emergency care, or the same emergency care. Injuries to nerves above vessels are quite common. Care of elbow injuries include assess the distal neurovascular function periodically. If you find strong pulses and good capillary flow, splint the injury in place in which you found it. Apply 2 padded bore splints to each side of the limb and secure with a saw or a band. Alternatively, you can mold a padded wire ladder splint or sand splint to shape of the limb. Cold, pale hand or weak or absent pulse and poor capillary field indicate that blood vessels have likely been injured. Consult medical direction immediately if the limb is pulseless and significantly deformed. At the elbow, apply gentle manual traction in line with long axis of the limb to decrease deformity. Fractures of the forearm. Fractures of the shaft of the radius and the ulna are common in people of all age groups but are seen most often in children and older people. Both bones break at the same time when the injury is the result of a fall or of an outstretched hand. Isolated fracture of the shaft of the ulna may occur as the result of a direct blow to it. So you have the night stick fracture. Fractures of the distal radius are known as the collar fractures. Severe deformity, distinctive appearance of the patient's arm. In children, the fracture may occur through the growth plate and can have a long-term consequence. You see the growth plate down there at the wrist area. To stabilize fractures of the forearm or the wrist, use a padded board, air vacuum, or pillow splint. If the shaft of the bone has been fractured, include the elbow joint in the splint. Splinting the elbow joint is not essential with fractures near the wrist. It's possible to elevate the injured extremity above the heart to help alleviate. Injuries of the wrist and hand. Injuries of the wrist must be confirmed by radiographs. Dislocations are associated with a fracture. Common wrist injuries are isolated, non-displaced fracture of the carpal bone, especially the scaphoid. Hand injuries vary widely, and some have potentially serious consequences. All hand injuries must be evaluated properly by a physician, and do not attempt to pop a dislocated finger joint back in place. Always take any amputated parts to the hospital with the patient. Fractures of the pelvis are relatively uncommon injuries, so responsible for a significant number of deaths in blunt trauma patients. Death results from a massive hemorrhage occur secondary to high energy trauma such as crush injuries, motorcycle crashes, and falls from significant height. A number of structures within the pelvis are at risk for injury within this fracture. So your bladder, urethra, rectum, vagina, sacral nerve plexus, veins within the pelvis, internal, external, iliac, and arteries in the lumbar region. Nerves in the lumbar and sacral region, and the femoral nerve. It may be accompanied by life-threatening loss of blood. So up to several liters of blood can be drained into the pelvic space and the retroperitoneal space. Often there are no visible signs of bleeding until a severe blood loss has occurred, and patients with pelvic ring disruptions who have stable injury may report pain in pelvis and difficulty bearing the weight. More severe injuries may be shown: profound shock, gross pelvic instability, diffuse pelvic and lower abdominal pain. There may also be bruising or laceration to the perineum, scrotum, growing, suprapubic region, and the flank. You may have hematuria and blood coming from the meatus of the penis and vagina and rectum. Lateral compression pelvic ring disruptions result from an impact on the side of the body. The side that sustains the impact becomes internally rotated around the sacrum, often associated with injuries in other regions of the body. So these figures show the lateral compression injury to the pelvis and a radiograph of the lateral compression injury. Anterior-posterior compression of pelvic ring disruptions may occur following a head-on injury, motorcycle crash, fall, or pedestrian struck head-on by vehicle. The force of impact compresses pelvis in anteriorly to posterior direction, causes pubic symphysis and posterior supporting ligaments to tear apart. Pelvis then spreads apart and opens like a book, and they have the open book pelvic fracture. So this is a potential for a massive blood. Vertical shear, major forces applied to the pelvis from above and below. On landing, force is transmitted through the legs to the pelvis, leads to complete displacement of one or both sides of the pelvis towards the head. Patient is likely to have significant shortening of the limb on the affected side and the risk for massive hemorrhage into the pelvis. Straddle fractures occur after a fall when a person lands in the region of the perineum and sustains bilateral fractures of inferior and superior rami. Does not interfere with weight bearing. Carries risk because of associated complications. Unopened pelvic fractures, life-threatening injury, presents presence of lacerations of skin in the pelvic region, vagina, or rectum. It is uncommon, and it is caused by high-velocity injury to subsequent massive hemorrhage. Even small amounts of blood found during vaginal or rectum exam should raise your suspicion for an open fracture. Care for a pelvic fracture includes suspect pelvic fractures if the patient has sustained high-velocity injury or and experiences discomfort in the lower back or abdomen. Deformity or swelling may be difficult to see. Most reliable sign is simple tenderness on forearm, compression, and palpation. Assess for tenderness. Place the palms of your hands over the lateral aspect of each iliac crest. Apply firm but gentle inward pressure on the pelvic ring. When the patient lies supine, place palm over the anterior aspect of each iliac crest. Apply firm downward pressure and use palm to firmly but gently palpate pubic symphysis. With injury to the bladder or urethra, lower abdominal tenderness and hematuria or blood at the urethral opening may be present. Perform a primary survey. Treatment should include monitoring ADC, spinal mobilization, IV access of at least one large bore catheter, possibly two if you can get it. Management involves reducing the amount of bleeding and decreasing the degree of instability. Methods of stabilization include application of a PASG or pelvic binder, or just tying a sheet around the pelvis. If you're going to tie a sheet, which is usually the most common way, make sure you pull a lot of traction on that sheet itself. Once immobilized on long backboard, the patient should be rapidly transported to a trauma center. Administer IV fluid and avoid hypertension. Dislocation of the hip is only after a significant injury. Almost all dislocations are posterior. The femoral head is displaced posteriorly to lie in the muscles of the buttocks. Suspect hip dislocation if a patient has been in MVC, has a contusional laceration or obvious fractures in the knee region. Femoral head rarely dislocates anteriorly. Legs are swollen and forcibly spread wide apart and locked in that position. So, posterior location of the hip is frequently complicated by injury of the sciatic nerve. When the head of the femur is forced out of the hip socket, it may lead to partial or complete paralysis of the nerve. So generally only dorsiflexors are involved, and it causes a foot drop. Patients with posterior dislocation of the hip typically lie with hip joint flex. Thigh is rotated inward towards the midline of the body over the top of the opposite. This thickness signs include severe hip pain, strong resistance to any attempt to move the joint. Lateral and posterior aspects of the hip region will be tender on palpation. Check for this sciatic nerve injury. Assess the sensation of motor function in the lower extremity. So do not attempt to reduce the dislocated hip. Split in position of the deformity. Place the patient supine on scoop stretcher along backboard. Support affected limb with pillows or rolled blankets secured to the entire limb to the backboard with long straps so that the hip region will not move. And then provide prompt training. Fractures of the proximal femur. Common fractures, especially in elderly people. It's usually called hip fractures, and it really involves the hip joint. The break goes through the neck of the femur, the intracranial middle region, and across the proximal shaft of the femur. Occurs most often in older patients, and particularly patients with osteoporosis, but may result from high energy injuries in young patients. Patients display a variety of characteristics. Deformities, long leg externally rotated, and the injured leg is usually shortened than the opposite, uninjured limb. Patients typically are unable to walk or move the leg. The hip region is usually tender on palpation, and gently rolling the leg will cause pain, but will not do further damage. Assess pelvis for any soft tissue injury, bandage appropriately. Assess pulses and motor and sensory functions. After assessment, splint the lower extremity. Age of the patient and severity of injury will dictate how to splint the fracture. All patients may have significant blood loss, so O2 vital signs and be alert for signs of shock. And always initiate your IV therapy. In the foot or leg, if the foot or leg below the level of the fracture shows signs of impaired circulation, apply gentle longitudinal traction to the deformed limb in line with the long axis of the limb. Gradually turn the leg from the deformed position to restore the limb's overall alignment. Monitor for shock, full spinal mobilization, and establishing vascular access. Consider calling for paramedic backup and administer pain medication if it will not delay transport to a trauma center. Knee injuries. Different types of injuries include ligament injuries, dislocated patella, and a fracture. Assess the patient's knee to reveal any significant findings. Injury of knee ligaments, often seen in recreational and competitive athletes, and ligaments on the medial side are most often an injury. Dislocation of the knee, the ligament may be damaged or torn. This direction of dislocation refers to the position of the tibia with respect to the femur. The anterior posterior ligaments are commonly damaged. In posterior dislocations, a direct blow to the knee forces the tibia to shift posteriorly. The medial dislocation results from a direct blow to the lateral part of the leg. Patients typically report pain in the knee and report that the knee gave out. If adequate distal pulses are present, splint the knee in the position in which you found it and promptly transport the patient. Do not attempt to manipulate or straighten any severe knee injury if there are good distal pulses. Medical direction may instruct you to realign a deformed pulsal femur. Just make only one attempt to do this. Fractures about the knee may occur in the distal ends of the femur, at the proximal end of the tibia, or in the patella. Easily to confuse a non-displaced or minimally displaced fracture about the knee with a ligament injury. A displaced fracture about the knee may produce significant deformity that makes it look like a dislocation. The patient has a good distal pulse, splint extremity in the position in which it was found. Elevate the leg to the heart level and apply cold pack. Monitor the distal neurovascular function en route to the hospital. Dislocation of the patella. This most commonly occurs when teenagers and young adults engage in athletic activity. Minor twisting may be long enough to produce the problem. Displacement of the patella produces a significant deformity in which the knees are held in a significant flexed position. Patella is displaced to the lateral side of the knee, so splint in the position in which you found it. To immobilize, apply padded boards to the medial and lateral aspects of the injury. Injuries to the tibia, fractures of the splint of the tibia fibula may occur at any place between the knee joint and the ankle joint. These are both bones fracture at the same time, and a single fracture may result in a severe deformity with significant angulation or rotation. Open fractures of the tibia are common. Stabilize with a padded rigid long leg splints or air splints that extends from foot to upper thigh. Affected leg should be secured to the opposite leg and correct severe deformity before splinting. So, apply a longitudinal traction, restore it to a position that would take a standard splint. Sometimes associated with vascular injury, realigning the limb frequently restores an adequate blood supply to the foot. Ankle injuries result from sudden forceful movements of the foot. Actual load is transmitted through the foot, causes the talus to impact the distal tibia, leading to the fracture. Signs and symptoms: pains, deformity, and swelling. Stabilize ankle fractures using a commercially available or a splint or a pillow splint. Leave toes exposed for frequent checks of distal neurovascular function. And evaluate the extremity to the heart level and apply cold packs to reduce the fracture dislocation of the ankle. Relax the calf muscle by flexing the patient's leg at the knee to allow the foot to move more freely. Rotate the foot back into its own position without forcing it. Reassess the distal neurovascular status and splint the extremity in reduced position. When able to reduce the fracture dislocation, notify the EMD, splint the ankle position as if found, and provide rapid transport. The injuries result in the fractures of the tarsals, metatarsals, or phalanges of the toes. Toe fractures are especially common. Of the tarsal bones, the calcaneus is the most frequently fracture. Injury usually occurs when patient falls or jumps from height and the leg lands directly on the heel. Force of the injury compresses the calcaneus, producing immediate swelling and ecchymosis. Frequently, the force of the injury transmitted up the legs up to the spine, producing a lumbar spine fracture. If you suspect the foot is dislocated, immediately assess the patient's pulses and motor and sensory functions. Injuries of the foot associated with significant swelling, but rarely with gross deformity. Vascular injuries are not common. Lacerations about the ankle and the foot may damage important underlying nerves and tendons. Puncture wounds of the foot are common and may cause serious infection if not treated early. So to splint the foot, apply a rigid padded board, air splint, or pillow splint. Leave toes exposed and assess neurovascular function. Transport the patient in a supine position to allow elevation of amputation. With partial amputations, be sure to immobilize the part with bulky compression dressing and a splint to prevent further injury. Do not cut off any partial amputations, which may complicate later reattachment. Hemorrhage from amputations can be severe, life-threatening. Control bleeding, treat with shock. If the bleeding cannot be controlled, quickly apply a tourniquet just above the site of amputation. Make every attempt to preserve an amputated part in optimal condition. With complete amputation, wrap the amputated part in a sterile dressing and place in plastic bags. Follow your local protocols regarding how to preserve amputated parts and put the plastic bag in the cooler container filled with ice. Float the bag containing the wrapped part on a bed of ice water and do not pack it in ice. Keep the part cool without allowing it to freeze or develop frostbite. Do not attempt to warm the amputated part and do not place the amputated part in water. Provide rapid transportation to the appropriate facility, and when a limb or part of a limb has been amputated, notify the ED in advance of the type of case and estimated time of arrival. Administer a bolus for significant blood loss or hypertension. Patient emotional stress can lead to psychogenic shock. With sprains and strains, it's similar to fractures. Rest, immobilize the splint and injury area, cold pack, compress with elastic bandage, elevate, splint, reduce or protect the part from weight bearing and pain management. And that's the end of this chapter. Following a fracture, the quadricep muscles begin to spasm. The muscle spasms often produce significant deformity of the limb, and usually the limb also shortens significantly. Fractures are occasionally open, and fragments and bone may protrude through the skin. Patients often experience significant blood loss and cover any wound with dry sterile the patient to the backboard with the extremities at their side. Principles of splint: remove clothing from the area of any suspected fracture or dislocation. Assess and record the patient's neurovascular status distal to the site of the injury, and cover all wounds with a dry sterile dressing before splitting.